How much time do you have today to spend?
I actually don't have any classes to teach today, so I can do whatever you need me
Okay.
to. I
'Cause
do have to be somewhere after lunch.
I
but-
haven't scanned at all, so
Yeah.
I'd like to be able to scan
Absolutely.
Brian if possible.
Mm-hmm. Sure.
How do I open the shutter?
Oh, it's on the front. There's like a little. Sorry.
You're fine.
I told him it's been like 10 years since I've used this thing, so there you go.
Yeah, I haven't seen a camcorder in a while.
I know, he
It's
asked
always
me
their
if I had
phones.
one, and I
Yeah.
was like, I do, but I have to go like dig it out.
Okay. So,
It's a little grainy. I might have to zoom in.
all right. So, in your parasternal long axis view, the first thing you want to do is you're going to take an image with your depth kind of out, because you want to see if there's any fluid around the heart. You want to see if there's a pericardial effusion, which would go above the aorta, or a pleural effusion, which would be below the descending aorta here. And then you would just store your image. On the GEs, it can be set up to store like before you hit the button, it records what you just saw, or it can be you hit the button and it records after. It just depends on what they've got at your lab. So you would hit image store, and it's going to store a clip. Usually it's based on your EKG, and it'll store 3 heartbeats. If you don't have an EKG hooked up, it'll do a certain number of seconds. So that's the first image. So you just image store. I have to put in a name or it won't do it. So let me do that real quick. And that way I can actually take pictures for you guys. I'll just pull somebody up. Okay. So depth out, get your image store. Sorry, I haven't used this one in a while. Let me create a new exam. This is a little different from the new ones. It's a lot easier to do now. There we go. Okay, now we should be able to store. So depth out, image store, we'll do your clip.
So each time you're clicking that, that's to start the clip and then to end the clip.
Yeah, now
Okay.
if it's recording before what you just did, you just hit image store and it'll do like the last 3 beats.
Okay.
So if it's doing after, then you would clip it.
Okay.
Yeah, so it just depends on how they've got it set up at your place. So once you get it where you want it, the first thing you want to do is zoom on your valves. So you just zoom and get on the valve. I usually zoom on the aortic valve. Let me come back out of that. You should be able to just move your trackball to get it where you want it. If you want to make it a bigger image, you hit the top button here, and that should move it, make it a little bit bigger for you. So then you're going to capture that. And then I go ahead and get a good image of it, freeze on it, and you're going to send it back to where that valve's open. You can see the leaflets are open here and here. And that would be in systole. And you're going to measure your LVOT. So you measure, and you're going to come down to dimension, and you're going to pick LVOT diameter. And this one goes in just behind where the leaflets insert. So here's your leaflet. You're going to go right in that little notch there. And then this is the other leaflet, and it inserts here. So you want to make sure that you're cutting the annulus perpendicular to it. This measurement is usually around 2 centimeters, but you want it to be exactly what it is because it's a very important measurement. And then you just take a picture of that. You can come back off of your zoom. And now you're going to do color. And that box works just like the other. It's got the top thing to make it bigger and lower there, that little button. So you can just look for any regurg, which would be coming this way. Look for stenotic flow, which would be going that way. So your flow in this image is a little harder to tell exactly if it's going to be red or blue, but it's usually red going out this way. Just know that the flow in the heart is coming from left atrium through the left ventricle and then out the LVOT and out the aorta. So then you can put color over your mitral and look for any regurg, which would be going back this way. And you're just storing clips as you go. Then you want to put color over your septum. You're looking for any ventricular septal defects. Those would be going usually from left to right, so they would be red coming across your septum. You just capture that. Okay. Then you can do your image, just your 2D measurements. So you let it run a few beats, just get a good image of it. Freeze it. You're going to cine back to end diastole, where the ventricle's the biggest, your valves are going to be closed. You're going to hit measure. And for this one, you just do IVS diastole, and it should start your package to where you can just go interventricular septum, and then it'll let you click again here, come down, make sure you're getting just the wall. You don't want to come all the way down. The wall's right there. And so you're going to get that for your left ventricular internal diameter. Click again, and then that is your posterior wall. And all of these are your diastolic measurements. Some places will measure the right ventricle too. And then just take your picture, don't unfreeze. You're just going to hit trackball, and you're going to cine back until it's systole. So your chamber is going to be the smallest, your mitral valve closed, and your aortic valve should be open. So that is systole. You're going to hit IVS systole here, and you're going to do the interventricular septum again. Not every place will remeasure this. Sometimes they just measure the chamber. Click again. It's going to give you your next caliper. It's just going down the line. It should go ahead and go to the next one for you. So that's your chamber. And then this is going to be posterior wall. And always just, you can peek over here and make sure that it's measuring what you want it to measure. So we're doing posterior wall now. Now the next thing I like to measure is the left atrium, and I don't see it on here. We don't always have it set up exactly like we want it though on this machine, since we didn't set it up. We'll do the ascending aorta next. So this is the aorta. The valve is right here. Ascending would be out past this. So like that.
So you're just getting past the
Mm-hmm.
valve.
Go past that sinus area. Yeah. Let me see why I don't have my left atrium on there. I'll have to add that. I haven't used this one. Sorry, guys.
Would
So
you-
we'll just do a generic, and I'll show you where you would measure it. So left atrium is measured in systole also, because that's where it's the biggest. And you just measure inner to inner because you're measuring the inside of the chamber. So right there. And then you would just take a picture of all your measurements here, and then you can move on. Any questions about any of those? Or how to do them?
I'll have a million ones.
Okay, we'll do it.
That was perfect.
Okay. So the next thing that I usually like to do, and which is really good to do, is once you have your parasternal long axis, you're going to slide up towards the head, and you're going to get the aorta in more. So this is even more of that ascending aorta. I'm going to turn the gain up just a little bit. Gain's here. And the reason you want to do this is anytime there's aortic stenosis or a bicuspid aortic valve, they're more likely to have a dilation of that ascending aorta there. So I'm just going to remeasure that ascending aorta since I can see it farther up. Now, you know the abdominal aorta can only be 3, the thoracic can be up to 4 before they consider it aneurysmal. Okay, so a lot of places don't do a lot of M-mode, but it is still on your registry. So I want you to know how to do M-mode and what measurements you do with it. So when you're back on your parasternal long, again, forgive me for the left-handed scanning here, you're going to hit your M-mode. You can get over your, just in the ventricle here, you're getting an M-mode of the left ventricle. There we go, that's better. So on this M-mode, this is your right ventricle, this is your interventricular septum, this is the left ventricle, and this is the posterior wall, or infralateral wall. You can measure these. A lot of places do not measure these anymore though. But if you were going to measure them, you would just do diastole here. This would be your right. Okay, it's not asking for right. Let me undo that. Okay, your IVS in diastole. So it would be thin there. Then your ventricle should be the largest there. And then there's your posterior wall, which is also thin. Then you would move up and do systole, which is right next to it, and you can see where it's squeezing, so it's thicker. So you're going to measure your IVS, your chamber, and your posterior wall. And that gives you an ejection fraction and everything there. So you would just take a picture of that. Like I said, most places don't measure that, but I do want you guys to know how to do that. Then you're going to do M-mode of your mitral valve. So this is mostly looking at the anterior leaflet of the mitral valve here, and this is the motion of it opening, and it opens in diastole. So this is anterior mitral valve leaflet. This is where it initially opens, so that would be your rapid filling. It starts to close, and then you have the atrial kick, which reopens it there. And then here's where it's closed. The posterior leaflet is right here, so you can barely see it, but they come together and are closed here. So here you can do some measurements on it that you might see and hear about on the registry. You're going to have your D to E excursion. So this initial point here is the D point, and you just click on it and go up to the E point, and that gives you how far that valve's opening. The next thing would be the E to F slope, so you begin at that E point, come down to the F point. So that's just how rapidly that valve starts to close. It has to do with the pressures. And then the last thing that you measure is this is really all you measure here. There is an E point septal separation you can measure. I'll just go ahead and do it right here. So it's from the E point up to the septum, and that would be EPSS, or E point septal separation. So that just kind of shows you, is your chamber too big? Is this valve opening all the way up to this interventricular septum? Or, you know, is it just barely opening like with mitral stenosis? Okay. And the last M-mode that most places do, if they do any, is going to be of your aortic valve opening and closing. So just, we're still in that parasternal long, you're just going to move over to that aortic valve. If anybody measures any M-mode, this is the one that they measure. So I would say this is probably the most important one to know how to do. Let me get a good picture of it. Sorry. And of course, with anything, the better your 2D pictures, the better your M-mode's going to be. Get it up here, it might be better. There we go. might have caught one. So let's get it again. Alright, so what you're looking at here, this is the RVOT, this is your aorta, the aortic root, and this is left atrium. So you're looking at, this is where the leaflets are closed, so that would be in diastole, and then they snap open right here, and this is what we call the box. So here's one, and here's a better one to see. It's really not that easy to see on this machine, but you're going to measure. First, you're going to measure the aortic root, which will be from the anterior root to the posterior root there. You do it right before the opening of the valve. The next one you measure is the left atrium. You do that in systole, at end systole, where it's open the widest, where the valve's the widest, I should say. And then the valve opening itself, your aortic cusp separation, this is the right coronary cusp, and the non-coronary cusp is here. So you measure from the initial opening of the right cusp down to the non-cusp there. And it gives you just how wide that valve's opening. Okay, so that's the M mode that you would do. From there, I'm still in peristernal long, but all you're going to do is you're going to take that probe and you're going to angle toward your patient's right hip. You're not going to move your reference point, you're just sweeping towards the right hip. And that's going to give me my inflow view, my right inflow view. So this is your right atrium, right ventricle, and tricuspid valve here. And then you would just take your clip store. You're going to put color on it. And this is mainly looking for tricuspid regurg here. Regurg would be blue coming back in here. We have a lot of flash though. So you put your cursor and you're going to use continuous wave for this, because we want to see if there's any flow at all. So you're just going to kind of sweep through that valve with your cursor, just like you would if you were looking for, you know, any kind of abnormal flow in a vascular study. Earlier. Tricuspid regurg is one of those things, it may come and go throughout the study. It depends on how they're breathing in, that kind of thing. Sometimes it also depends on how hydrated they are. So regurg, hers, she just has a tiny little wisp right here, and that's, you know, pretty normal. So we're going to measure that. You're going to hit measure, and you're going to come down to tricuspid valve. And you're going to do TR Vmax just to get the maximum velocity. And hers is right here. I'm going to turn the gain up just a little so you might be able to see that. It's right there. If somebody has a good TR jet, that means it's more significant, and you'll actually see a full envelope below the baseline there. And tricuspid regurg is going to be in systole, during systole on your EKG. Okay, so that's really all you're getting from that inflow view. You're going to go back to peristernal long, and then from there you just angle towards the left shoulder. This is going to be the outflow view. This is another one of those not everybody does, but you guys need to know how to do it. It is one of the tougher views to get because you're fighting lung. And all you're getting here is the RVOT, pulmonic valve, and pulmonary artery. And you would just capture, turn on your color. So in this one, the normal flow is going out of the heart this way, away from your probe, so it all should be blue. Usually you might see a little red flame up there. That would be your insufficiency or regurg. And about 85% of people have pulmonic insufficiency, at least a little bit, so that's okay to see. You're going to continuous wave through there. So this is your normal pulmonic flow. If there was regurg or insufficiency, it would be here. Okay.
So normal is below the baseline?
Yes, because it's going away from your probe there.
Gotcha.
Yep. So we're going to come up and do pulmonic. PVV max is just going to give us a maximum velocity here. And pulmonic normal flow should be during systole because it's open the same time the aorta is. Any insufficiency will be up here. I don't see anything to measure. So, okay. All right, from there, for all these pictures, we've had our reference point towards that right shoulder. All we're going to do to get our short axis is go from the right shoulder to the left shoulder. So I'm just turning my probe counterclockwise, and that's going to give us our short axis of the heart. There's 4 different levels we look at here. We're going to start, you can either start at the bottom of the heart and go up, or the top and go down. It doesn't matter. So I'm just going to start at the aortic valve level, which would be at the superior portion of the heart there. Okay. So for this one, you'll have your aortic valve in the middle. Pulmonic valve will be on kind of the left of your screen, and then tricuspid valve will be on the right of your screen there. So I can get a better picture. Here we go. Sometimes you have to move up a rib space to get a better picture, or down. It just depends, of course, on your patient. There's a little better. A little fuzzy. This machine is old. Okay, I'm going to start on pulmonic valve here, so we're just going to look at it again. You can see pulmonic valve there. This would be the RVOT above it and the pulmonary artery below it. So that's going out into the lungs there. I'm going to put color on it again. Again, the flow should be blue because it's going away from our probe. And it's going to be below the baseline. Continuous wave will give you all the flow there. Some places will do pulse wave just to get the flow right past the valve. Better picture. There we go. So this is your normal flow. And then you can measure it again. Just do a PV Vmax again on that flow. And then we're going to get tricuspid valve over here. So this is tricuspid valve. So this would be your right atrium, and the right ventricle would be above that valve. Now this flow is going from the atrium to the ventricle. So its normal flow should be coming up towards us here. So that should be red, of course. And we're going to Doppler that. And use continuous wave again because we want to see if there's any flow at all. And we don't expect to see tricuspid regurg, but if we do see it, it's usually just a wisp on a normal patient. If somebody has pulmonary hypertension, they might have a lot more. That little tiny wisp right there is tricuspid regurg. And again, you would just do tricuspid valve and Vmax. On the patients we scan in the hospital, you're going to see a lot more tricuspid regurg. That's one of the most common things to see. Alright, so I'm still just in that same view at the same level. I'm going to get my aortic valve. It's kind of right in the middle there, right in the center. And I want to see all 3 leaflets. Pull your shoulder back just a little bit for me. Perfect. Good. There we go. Okay, so you really want to get the 3 leaflets opening and closing here. You can see this is the right coronary cusp, the left coronary cusp, and the non-coronary cusp. So you're going to zoom up on that. This is very important that they see those 3 leaflets. They're going to look for stenosis here and any congenital, like a bicuspid aortic valve, that type of thing. So you would just get on that and you would store it. And then I usually come back off of zoom to do my color here, but you can do it with it zoomed up. The flow here, you just want to make sure there's not flow when it's closed. So you're looking for insufficiency here.
So you should see the color completely go away.
Yes, and it's hard to see because it is happening so fast, But if you cine through it, you can see when it's closed, right there, there's no color. You'll see it though, if there's insufficiency, you'll actually be able to see like a little dot of flow that stays there when it should be closed. Okay, so that's tricuspid valve, pulmonic valve, aortic valve. This is left atrium, right atrium. This is your intraatrial septum here. So you can put color on this intraatrial septum, looking for any communication between there, like a atrial septal defect, that type of thing. And then you can capture that. But that's pretty much everything that you do at this level. We're gonna just angle down a little bit, and we're gonna get the mitral level. So this is left ventricle with a mitral valve, anterior leaflet, posterior leaflet. And then this is right ventricle here, so this is interventricular septum. And this is what we're actually talking about in class this week, was the wall segments and the names. So if you look at your left ventricle, right ventricle, you can say this is all septum here. So this bottom half would be inferior septum, anterior septum. This would be anterior. This would be anterolateral, inferolateral, and inferior wall here, where this papillary muscle connects. So that's your 6 wall segments. Always start at your septum, and that way you have a base to know where you started from and how to go around. So for the mitral level, you're really looking at the wall motion. You want to know, is it all squeezing to the middle equally? And then you're going to capture that. Some places will put color on that mitral valve and on your interventricular septum there. And they'll capture it. Then you're just going to angle down a little bit more. Now this is your papillary muscle level. So this is the posterior medial papillary muscle, and that's the anterior lateral papillary muscle. And they're just looking at wall motion here, so you're just going to capture it. Make sure you can see all the walls and that you can see that endocardium really well. So you just watch it for a few beats. And then you're going to angle down to the apex. You might have to move below the rib there. You're just getting that apex. You're looking to see how it's squeezing. And on your apex, it only has 4 wall segments, so it's going to be the part where the right ventricle is your septum. Then this is anterior, lateral, and inferior. Okay, so that is all of your peristernal long and short axis. And then we'll go to apicals. Any questions before I move?
No, that's
Okay.
perfect.
Okay. All right, I'm going to be under your breast, so let me cover you this way. Your reference point is towards the bed for apicals. Apicals are usually people's least favorite view to do. Give me just a minute to get situated. Okay. I know it hurts on the ribs, I'm sorry.
It's not the ribs.
I gotcha. That breast tissue.
Yeah.
Okay, so you're going to get your 4-chamber first. The first image they want you to do is that with increased depth, just looking for any fluid around that heart. So you would just go out in your depth and capture it. Then you're going to come back in. You're going to have left atrium, right ventricle, left ventricle. So this is intraatrial septum, interventricular septum. You're showing that wall motion here, so you'll get just the best picture you can of it. Your walls, this is going to be inferior septum, and this is anterolateral. Pulmonary veins are coming in here. So you capture an image of this, and then it doesn't matter which side you start on. It depends on whatever the protocol is where you're at. I always start on my left side, and I'll do my color. You're going to put color over your mitral valve. Okay, your flow should be coming from the atria to the ventricle, so it should be red coming towards you. So we've got good red flow there. We're going to do pulsed wave now, and we're going to put it right at the mitral leaflet tips, because this is right where that flow is coming into the ventricle. And we're going to get mitral inflow or normal flow. Okay, so the mitral has this M-shaped flow. This is the E, this is the A, this is that initial filling, and then this is that atrial kick that pushes that rest of the blood into it. For the mitral, the normal measurements you're going to do, you get a mitral valve, and you're going to do the EA velocity here. So you measure your E point, which is always the first peak. The first peak is always your E. It's going to let you do a decel time, which tells it how fast that opens. You go all the way back down to the baseline for this one. And then you're just going to do the A. That's just the A velocity. So you do an E, a decel time, and an A for the mitral on every patient. A lot of places will have you do continuous wave through here now. This is looking more at how that flow's going through. We're gonna hone in on it just a little. Normal flow again is above the baseline here. This is kind of a little more advanced measurement. Not every place does this, but it's called the mitral valve trace. So you would actually trace from the baseline. You're going to trace the E, come down, and then trace your A, and then go back down. So that just gives them more information as far as how that valve's opening, the pressure in it, if there's any stenosis, that kind of thing. The other thing we look for here is going to be regurg. So regurg would be below the valve here, and it should be blue because it'll be going away from the probe. We're going to look for that with continuous wave. And you're just going to sweep through. This is aortic flow we're picking up there, so just be careful not to mistake that for regurg. I don't see any regurg up here, so I don't really expect to see any on my Doppler. If you did though, it would be, here's the normal flow in diastole, it would be here in systole, and it would look more rounded than this does. This is, we're picking up LVOT flow there. So she doesn't have any regurg, but if she did, it would be in this area. Okay, the next thing that they do is something called tissue Doppler, and what that is doing is measuring the myocardial motion at the mitral annulus. So on this, it's called TVI on this machine. It's tissue velocity imaging, but you'll also see it TD for tissue Doppler. So you're going to do a pulse wave at the septal annulus. You want to be right at the level of the valve there. And this is helping them know how well that myocardium's moving. This is something for diastolic function. So you're going to go to measure, and this is called E prime for tissue Doppler. So it looks just like your mitral flow, but it's reversed. It's on the under the baseline. So the first one's the E, the second one's the A, always, just like with the normal mitral flow. But this is just measuring myocardial velocity. So you measure your E point there, and it gives you E prime, and it does a ratio with the mitral flow. Then you also do the septal right at that annulus with pulse wave again. And it's giving you an E and an A, and you're just going to measure the E. Now, a lot of machines, it'll actually say septal and lateral, so that you can pick two and have two separate measurements. That should be how your machine's set up. So the one here will be septal, and then of course this is the lateral. So just make sure you choose the right one. Okay. Another thing that a lot of places will do is a left atrial volume. So you just watch it for a few minutes, freeze it. You're going to cine back to end systole, where that ventricle is the smallest, the atrium's the biggest. And we're going to measure the volume. So So you'll come down to volume. Let's see, we don't have it set up, of course. There should be, under volume, you should have one that says left atrium 4-chamber, and then one that says left atrium 2-chamber. So you would pick the one that says left atrium 4-chamber. I don't have that, so I'm going to pretend for you. So we're going to pretend this is a left atrium 4-chamber. You're going to start here, and you're going to trace the inside of the chamber of the left atrium. You do not include pulmonary veins, and you don't include the left atrial appendage. And so you would just come up to the baseline, you would click it. This is the length. It usually picks the longest length for you, and then you would just set that and give it a volume. You do this in 4-chamber and 2-chamber. The other thing that you can do, I don't know if they'll have you do this at your site or not, but you do an ejection fraction here. So that is where you would actually do biplane, and then you would pick 4-chamber, and you're just going to trace the endocardium here. That's why you really need to see that endocardium well, and a lot of times you have to use Definity to see this. Some machines, especially the newer GEs, have an automatic, like artificial intelligence that does this for you, but you need to know how to do it just in case. So you do it in diastole when it's the biggest, and then you cine back to systole where it's the smallest, and you do it again. Just pick systole and then trace the inside. You'll do that in 4-chamber and 2-chamber. Okay. But like I said, the newer machines have artificial intelligence that will measure it for you. All right, so that's pretty much all you're doing on the left side. Some places will Doppler a pulmonary vein coming in. They come in here, so that's where the flow is coming back from the lungs to the left atrium. And you would just pulse wave right where it comes in here. And that flow should be above the baseline. It has an S, a D, and an A reversal. Most of the time they're just showing it. And then the other pulmonary vein will be over here. Usually this is the one they're going to Doppler though. Again, that's not done on every echo. Okay. Now we're going to do the the right side. We're going to get that tricuspid regurg again. We really don't worry about tricuspid stenosis on adults. That's usually a congenital thing they find in babies. Most of the time on a routine echo, you're just getting tricuspid regurg, looking for it. But normal flow would be above the baseline in diastole.
So this is continuous wave.
Continuous wave again, sorry. And it's just looking for it again. We looked for it in our parasternal long inflow view, and we looked for it in that short axis too. But there's just that little tiny bit right there again. And you're just going to do tricuspid valve Vmax on that right there. Okay. Depending on where you're at, they might do some other right-sided measurements. If they do, let me know and we'll go over them. Otherwise, I don't want to get too far in depth on it. You're going to put color on your interatrial or interventricular septum here and do a capture. And then you'll put color on your interatrial septum and do a capture. Okay, from this view, the next thing we're going to do is a 5-chamber. So all you're doing from your 4-chamber, you're just angling towards your patient's head a little bit. Sorry. There. And this brings in the aorta right here in the middle. So this is aortic valve. This would be left ventricle, right atrium, left atrium's kind of back behind there. Above that valve is the LVOT. Here's the aortic valve, and this is aorta. So this flow is going away from our probe. So it should be mostly blue. You're going to put your cursor above the valve, and we'll do a pulse wave there, and that is your LVOT flow. That should be below the baseline. This is LVOT flow, and it's during systole. So you're going to do aortic, tell it LVOT, and we'll do a trace. You're going to start right at the baseline and just trace your valve flow there. Whoops, sorry. and go back up to the baseline. So this is LVOT trace. This is more accurate for aortic stenosis. You can do just a VMAX. We'll go ahead and do one just to kind of show you what it looks like. It would just be the peak flow there. That's not as accurate, but a lot of places that's all they do unless they see stenosis. So in that same picture, you're going to put your color back on. We're still on our aorta there in the middle. You want to be good and parallel to this flow to get your most accurate velocity. It's very important on this picture. So here's our aorta going out. We're going to do continuous wave now because we want to know what the highest flow through the valve is. The other was LVOT just before the valve. This is through the whole valve. Again, the flow's in systole. You can see the valve click here. This is opening and that's closing, so you know that's a good aortic flow. We're going to trace it again. You're going to trace inside the valve click. And then just trace it as close as you can and back up to the baseline there. So that is your aortic flow, and then you can do a VMAX also. Some places, if there's not stenosis, they'll just do that instead of tracing it. Okay, so from your 4 chamber, all I did was angled back out of her, away from her head, back into a 4. You're going to turn your probe counterclockwise, and we're going to go into a 2 chamber. So this is just the left side of the heart, left atrium, left ventricle. This is coronary sinus, and this is left atrial appendage over here. And mitral valve, of course, there. So you would capture that. You're going to put color on your mitral again. Some places will remeasure that mitral inflow like we did a minute ago. So you would do pulse wave, and you're going to get your normal flow, your E and your A with the decel time, and just the E, the A, and the decel time there. And then you can also do continuous wave again here, looking for MR, which would be below the baseline. I'm not seeing any. I'm still picking up some of that LVOT flow there. Right there might be a little touch of MR, but not enough to measure.
For pulse wave in the 2-chamber mitral view, where do you put the sample gate?
At the leaflet tips. So your color would be on. It's going to be at the leaflet tips where the flow is coming into the ventricle there. So just right in the red at the leaflet tips of the mitral valve.
Cool.
And that's going to give you your best E and A. Okay. The only other thing from 2-chamber, you're going to remeasure your left atrial volume here, and then you're going to remeasure your EF here in diastole and systole. This is inferior wall and anterior wall. That's the easiest one to remember, is your 2-chamber, because you've got infant, inferior, anterior. Okay, from there you're going to rotate counterclockwise a little bit more until you see your aorta coming in over here. And this is your 3-chamber view. Sorry, it's not the best. My hand's gone numb on me. So this is your aorta here, right there. So this is LVOT and aorta below that. This view is exactly the same as your parasternal long axis view. This would be interventricular septum. This would be your posterior wall, mitral valve, aorta. So this is just like that parasternal long axis. We've just turned it up on its side, kind of on its end there. For this view, you're going to just color your mitral again. Most people don't do many measurements here on the mitral, but you do want to redo your aorta here. And you can just put your continuous wave through there and get your aortic flow again. There. So this is normal aorta flow. If there was aortic insufficiency or regurg, same thing. Let me show you the time in here. So here's normal flow. There, that's better. Abnormal would be up here and it would look like a slope. I don't see any on her, of course. Okay, so that's all the apical windows. Any questions about that? Good?
I can't see anything.
I know. You'll get to watch it back. So lay on your back for me. We're going to do subcostal. We're on the home stretch. Oh. Yeah, we can't completely cover you up here now. I'm just gonna go on top of your belly. So for the subcostal view, you're gonna wanna make sure that you're finding their sternum and you're just right below it. You don't wanna push harder than by sternum, of course. You're gonna see your liver, and you're going to angle up from the liver. The reference point is towards me on this. So it's going to be toward your patient's left side at 3 o'clock. This is going to give you a 4-chamber subcostal. Take in a breath and hold it. There you go. So you're going to do this with increased depth again, looking for effusions, capture it. Then you're going to zoom in on it and take another capture. Go ahead and breathe. In this view, the right side of the heart is on top of the screen. The left side's on the bottom. So this would be right atrium, right ventricle, left ventricle. Breath in and hold it. So this is intraatrial septum, interventricular septum. The main reason for this view is to put color on the septum and look for intraatrial septal defects, and then ventricular septal defects. Breathe. Okay. So another breath and hold it. On the intraatrial septum, if you see color on the septum, if it's red, that means it's a left to right defect. If it's blue, then it's a right to left. Breathe. Okay, so that's your subcostal 4-chamber. All I'm going to do is turn my reference point from 3 o'clock to 12 o'clock, so up towards your patient's head.
And that's your notch, right? When
Yes.
you're saying, okay.
Yeah. So I've got a short axis view now of the heart. And depending on where I'm pointing, if I'm pointing straight ahead, I should have their aorta right there in the middle. So this is your short axis aortic valve level that we saw in peristernal. It's the exact same anatomy. So this is tricuspid and pulmonic, aorta in the middle. And if I angle towards the patient's left, I'm going to go through each of the levels again. So this is mitral. Taking a breath and hold it. This is papillary muscle level and apex. The reason you want to know that is because if they don't have a good window for peristernals, like if they have emphysema, you might have to do most of your echo from subcostal. So, yeah, it's not fun, but it can do it. You can see there. So if I'm pointing towards the patient's left a little more, I'm going to have their aorta here. You guys should be familiar with that. Of course, your image looks backwards from what you're used to because we've got their head up here now and their feet here. So aorta, I'm going to angle towards her right, and here's her IVC. There's a hepatic vein. This is important because you want to know how well that IVC collapses. So in this view, I can see hers collapsing over 50%, which is what we want to see. If you're not sure, have your patient sniff quickly through their nose. Go ahead and sniff. And that will collapse the IVC. Go ahead and breathe normal. It should collapse at least 50%. That has to do with the right heart pressures. You're going to measure the IVC here. Most places will just throw a caliper on it. So it should be under dimension, and you should have IVC listed down here somewhere. I'm just going to do a generic dimension because it's not set up on this one. So you would just you measure right at the level of your hepatic vein, somewhere in there is a good place to measure it. And the IVC should be less than 2. Okay, so the other thing you can do here is put color on. This flow, of course, IVC is going back to the heart, and because we're angled this way, it's going to be nice and blue. So we should be below the baseline here too. I'm just going to pulse wave it to show it. And the reason I do that is because you can then come to your measurement, come down to your tricuspid valve, and you can put in right atrial pressure here. So this number is estimated based on what we're seeing. We're looking at the size of the IVC. Does it collapse? Is there good forward flow in it? So a normal IVC number here is going to be 5, 10, 15, 20 are the choices you have. 5 would be normal collapse, normal size. 10 would be it still collapses, but it's a little prominent. 15 is it's enlarged and less collapsing, and then 20 would be it's just not moving, it's stiff. That'd be like your severe heart failure patients on the ventilator, that kind of thing. So 5, 10, 15, 20 is accepted. They've changed those numbers now. A lot of places we use 3, 8, 13, and 18, I think, are the numbers. So it just depends on what your cardiologists want. But this is where you would plug that in, and you just put in, like I would put in 5 for her because hers was normal. What that number does is it takes the tricuspid regurg that we measured, and it adds 5 millimeters of mercury to whatever pressure the machine calculated for it, and it's going to give us the right ventricular systolic pressure estimation. That's something you can't get accurately unless you do a heart cath, but we can estimate it based on what we're seeing. So that's why we do that. Okay, so that is subcostal. Do you guys do suprasternal where you're at?
Mm-hmm.
Okay, so we'll do suprasternal because I do want you to know it. Either way, suprasternal is very important for patients with aortic stenosis, that type of thing. It should be good. All right, so your reference point or your notch is going to be at 1 o'clock. So not straight up to their chin, but just at 1 o'clock compared to their chin. You're going to be just in the little notch right there above their clavicles. And you don't want to push, of course, here. This is, we always call it the goozle. So all you're going to do from there, you're going to angle down into their chest a little bit. And you're going to start to see the aortic arch. Right here. So what we're seeing in this picture, let me get it better. Is ascending would be over here. This is the arch itself, and then descending is here. Right here. In the middle of that is your right pulmonary artery. So you need to know right pulmonary arteries in the middle, ascending, arch, descending. And we're going to put color on that. The ascending would be red because it's coming up. This could be red or blue because it's kind of going parallel to us, and then descending should be blue. Good descending there, we would capture that. You're going to continuous wave just to get the highest velocity through there. Descending aorta should be below the baseline, of course, because it's going away from us there. Ascending, if you could capture it, it's not always easy to get, is above the baseline, right there. So that's all you're really doing in this view. This is a good view if they do have aortic stenosis because you can get their high velocities here. Also, if they have coarctation, you're going to see it in this view. The only other thing with aortic arch, if they have aortic stenosis, you need to do that. That's an ASE recommendation. It has to be done. The PEDOF probe, the non-imaging cardiac probe that we use, you'll do it from this view. You'll also do it from right sternal and then apical. But that's something you really have to practice. It's just getting the highest Doppler of the aortic valve usually. All right, and that's a whole complete echo. Any questions?
Yeah.
Help!
Yeah.
Yeah. What have I got
What have I
into?
done? Yeah.
It's gonna be fine, I promise.
So you've already had one class in the fall
Mm-hmm.
do this,
I did.
and they did well.
Mm-hmm. Yeah, they're all doing 164 right now.
Okay.
Yeah, they carried on. I had one drop, but it was a personal thing.
Yeah.
Yeah, it was a work finance thing. Yeah. Yeah.
Do I press the same button to turn it
Yes.
off?